Good afternoon. This is the Healthcare Committee. Our afternoon session, we're going to take up H611, an act relating to miscellaneous provisions affecting Department of Vermont Health Access. With us, we have several witnesses. The first one today would be Addie Stromolo. I hope I pronounced that name right. You can start off by talking about H611. Thank you.
Great. Thank you very much for having me. Is my audio clear?
Yes.
Great. Again, for the record, my name is Addie Stromolo. I'm the Deputy Commissioner at the Department of Vermont Health Access. I'm actually going to hand it over to my colleague Alex to talk through the bill to start off, and then I'm available for questions as well as information about open enrollment, which I know had been of interest. Alex?
Okay.
Thank you, Addie, and thank you, Vice Chair McFawn and members of the committee. I appreciate your flexibility with me today. I have a fever, so I'm not trying to infect all of you with it. But I'm here today to give a brief overview of H611, which is before this committee as the DVHA technical bill for 2026. We have not had a technical bill in a few years, so this is the first one that has come through in my time with the department. So I'm happy to give a kind of item by item overview of what we are proposing, and we can go from there for further discussion. I'm going to share my screen here. And is that coming through for everyone?
Yep.
Okay, perfect. So for the record, my name is Alex McCracken. I use she, her pronouns, and I'm the Director of Communications and Legislative Affairs for the Department of Vermont Health Access. And today we're going to go through a walkthrough of the technical bill items, including a brief overview of why we're making these changes or why we're proposing these changes, and leaving time at the end for questions and discussion. I will also note that many of these pieces, being the nature of a technical bill, are rather scattered. They're a collection of adjustments and corrections from across various statutes that the department feels are advantageous to make at this time. So they cross a lot of different subject matter experts' expertise. So if there is follow-up questions that the committee would like to dive into, we're happy to return at a later time this week to get more into specific details if Addie or I are unequipped to. So we have 6 different items, and they are each in a section for the technical bill. So section 1 is the repealing of unnecessary pharmacy reporting requirements. There's a current statute requirement that DVHA Pharmacy, the unit within DVHA that handles our pharmacy side, to annually construct 2 lists of drugs experiencing larger than normal price increases. Pharmacy has indicated historically and continues to indicate that this is an unnecessary administrative burden. These lists are given to the Attorney General's office for their drug transparency reporting. And the most recent report concluded that the process of preparing the report itself is too challenging to provide any useful information, and that the DVHA information is specifically unhelpful because DVHA is prohibited federally from sharing drug-specific net cost information. So we're in alignment with the AGO on that this is an unnecessary reporting requirement, and they're not getting what they would want from it anyway. So our proposed solution would be to repeal or sunset the statutory requirement for DVHA to provide the information to the AGO, or the requirement for the AGO's annual report itself, which is reflected in the first option is reflected in the language in front of you in the bill today. Section 2 is changes to CURB membership requirements. The CURB is DVHA's Clinical Utilization Review Board. It is an advisory body of medical professionals which provides recommendations and clinical insight to the DVHA leadership team. Currently, the CURB is looking for ways to increase membership and participation, but it is statutorily set at a 10-member body. There's concern from the CURB that this is language that creates a barrier to members serving staggered terms, and amending it will allow more members to participate with a greater opportunity for diverse provider and geographic representation. This proposed solution in the language in front of you in the bill was created and approved by the CURB itself. So it is coming to you through DVHA and the sponsored bill, but the language originates with the body that it is specifically touching. Section 3 is around increased burial fund limits. The issue here is that certain funds set aside to cover future burial costs can be excluded from Medicaid financial eligibility. DVA has been approached in the past by interested parties, including the Vermont Funeral Directors Association, about increasing the burial fund exclusion amount, which has not increased since 2002. Very few things in the world have not increased since 2002. The state has authority to update its medical state plan or its Medicaid state plan to make this change without legislation. However, the current exclusion amount was put in place in response to a direct legislative action in 2002. So we feel it would be helpful and necessary to have the legislative language changed to correct that. So we would propose increasing the burial funds exclusion for purposes of Medicaid eligibility while incorporating guardrails to ensure the expected use of these funds. And specifically, DVA would increase the $10,000 cap on the prepaid burial arrangements to $15,000 and implement use of a Medicaid payback requirement in the agreement with the funeral home to the extent that funds are not fully utilized. The current $10,000 cap would continue to apply to other burial fund arrangements, such as designated savings accounts. This is language that we've worked on internally and also worked with Ledge Council on, and we're happy to continue workshopping that language with Ledge Council as appropriate. We don't talk about burial fund limits often in this room or others. Section 4 are technical
Excuse me,
updates
Alex?
to. Oh, yes, of course.
We have a question.
I'm
Oh,
sorry,
of course.
Alice, just looking to see if we have the right, because I'm looking at section 3 and it's got reflective health plan benefits and not burial fund limits. So I'm just curious. I just want to get organized. Oh, this
Oh,
looks
no.
like a different order. Because here's curb at section 4.
Oh, okay. Well, thank you for that. I will make sure that these are in the correct order. Hold on.
Maybe we have a different version
We have the as introduced version.
as introduced. Is that, you're working off as introduced?
Alex, are you working on the as introduced version?
I should have been. I thought I was. Let me make
Yeah.
sure
I'm
that
sorry.
I've got the. No. This is an easy fix. I can do this on the fly. Thank you all for your patience. It's been quite a start to the session, as I'm sure you were all feeling as well.
You tell us when you're ready and then you can continue.
So you're saying that the next thing in the as introduced version is the.
Well, I'm saying that section 1 is
Reflective health plan.
prescription drug cost transparency, but I don't think that's what you said in section 1.
That
No,
is
'cause-
section. That is
Oh, yeah.
our section 1 here.
Okay, so that's good. Section 2 is Medicaid and Exchange Advisory Committee. That's section 4, I think. If I'm understanding it right. I'm just trying to get oriented.
Absolutely. That is better than the alternative. Sorry, I'm looking at the bill now.
Oriented.
So section 2 you said was MEAC, then we can go to that.
Medicaid Exchange Advisory Committee?
Yeah.
Yeah.
Okay. So the technical updates to the Medicaid Exchange Advisory Committee. The federal government promulgated rules CMS 2442-F that change a state's obligation around the Medicaid advisory committees. We're basically requesting these changes in order to bring Vermont statute in line with federal changes while preserving our unique structure of a combined Medicaid and Exchange Advisory Committee. This would create alignment between state statutes and new federal rules. Technical revisions regarding term limits, committee membership, and the existence of the new Beneficiary Advisory Committee, which launched this year. And I'm sorry, the next section.
Section 3. I'm gonna let you,
Section 3 I have is reflective health benefit plans.
All right, perfect. That's what we have here. So
Yay.
section 3, these will all be updated before they're sent to you again. Apologies, members of the committee. issue being addressed. So the reflective health plans, this is a pretty simple fix. This came through your committee last year, Act number 2. We couldn't quite get Act 1. Confirmed the unmerged marketplace with individual and small group health insurance markets. That was existing statute. We just took out the sunset of it and codified it in statute going forward. But when we did that, there should have been a technical fix that removed references to reflective plans. Now that the small group market is separate from the individual market, small employers and their employees don't need reflective plans because the small group coverage doesn't offer federal subsidies, and the loaded premium issue only affects individual market plans sold on the exchange. So this is a really simple language fix to clarify that reflective plans are for the individual market only. And then next we have CURB, if I'm reading my tea leaves correctly. I did go over this previously because I was under the impression it was section 2.
Yeah. Section 4.
So this is where we have the changes to the Clinical Utilization Review Board, which I addressed previously. Happy to go into more details on that at any point. Then we have
Alex, I'm sorry.
Okay,
Since she addressed it before, but I was in another page because I thought we were in section 2. Can you just quickly repeat?
Of course, I'm happy to.
I would appreciate
Yeah.
Of course. So this, the Clinical Utilization Review Board is an advisory body of medical professionals. They provide recommendations and clinical insight to DIVA. The CURB approached DIVA leadership with this proposal to help increase the participation in the body. Like many of our statewide advisory committees, they're always looking to add new members that reflect a diverse geographic and provider representation. But that can be difficult to do, and something they're looking to do is change the statute slightly to allow greater flexibility in who can participate in the CURB and in what timing they can. So these language recommendations were brought to us by the board itself and come to you through this bill as an attempt to help bolster the membership and participation in the CURB.
Any questions from the committee on that?
I do have a question, but the two boards, the Exchange Advisory Committee, I think you said had 22, and this one here has got 10 members. Is that the same number we had? This one here says a minimum of 10 members.
Are you asking if the Medicaid Exchange Advisory Committee has the same limit?
Yes, if they both have the same numbers as before.
I don't think that the Medicaid Exchange Advisory Committee member limit is changing or anything around their membership is changing in these proposed language shifts. But the Clinical Utilization Review Board, the CURB, is seeking to amend the statutory requirement of it being a 10-member body. They feel that creates less, they would have greater flexibility to have greater participation if they were able to increase their membership.
So that will be, is that 10 all new, or is that just expanded a little bit?
That's the 10 is not a new amount. The 10 is what exists now. So the changes would be to remove the 10 limit so that they can have the number of participants that are willing to be a part of the CURB.
Okay.
If there were more than 10, then they could add to their numbers.
Thank you, Alex. So I see that on the B, like line 9, it says a minimum of 10, which is what you're talking about, adding a minimum of, but with that language, it could be 100, couldn't it?
It could be, and I don't think that's the intention. I think the intention is to allow members to serve staggered terms so that folks who are on the way out can overlap with newer members coming in, and that membership could sit more around 12, 13 consistently and not be capped directly at 10. If that's something that the committee is interested in exploring different language options as well, I'm sure we can have that conversation. And I'm actually appearing to the CURB tomorrow night. So if there is anything that the committee would like to ask or relay about this particular item, I'd be happy to bring it to them.
Well, sometimes it's helpful to have a maximum. I mean, it could be 15, it could be whatever, but I'd be curious to know what Curb thinks, if there should be a maximum, and if so, how much?
Absolutely. I can take that to them tomorrow and see what their body thinks.
Thank you.
Thank you.
Thank you. Were there any other questions on the previous items we've hit on? And again, apologies for the circuitous nature of this testimony.
You it is.
Okay, thank you. Go on to the next one, next section.
I see Representative Rebecca has her hand up.
But she's online.
Oh,
That means she's online.
No, I don't have any questions. I agree with Leslie that getting any recommended language around maximum numbers for that board would be helpful, but also full disclosure, Alex's testimony is in the correct order that it was originally brought to us. And I think that when we were pulling together the draft bill, we decided to change it to align with the order of statutes. So I just wanted to say, sorry, Alex, it's my fault, but you've done wonderful.
This mystery suddenly makes so much sense now. Okay, thank you. No, that's just a lesson for me to double, triple check. But thank you. I appreciate it. So I think we're moving on to our last item on the technical bill spread, which is the request to delay Medicaid coverage of doula services. As this committee well knows, Act 50 of 2025 requires AHS to begin pursuing a state plan amendment for doula coverage by July of this year. DVA supports the coverage of doulas and the services that they provide, and we recognize the utility and the importance that they serve in our spectrum of care. The department has significant concerns regarding CMS approval for coverage and the potential for increased federal scrutiny throughout this process. It's a hard line for us to walk to approach CMS with requests that we're fairly sure are not going to be approved at this time. We would propose pushing back the date to seek a state plan amendment to July of 2028 to create more runway to properly fund and implement this coverage addition. DVA has also been made aware that OPR is seeking to extend their timeline in conjunction with ours. And I also want to note for this committee some encouraging work that's happening currently with DVA being engaged with OPR, VDH, and other external stakeholders and advocates in a doula services working group to keep this process moving forward. We've met twice so far, and we're looking to schedule our next meeting later on this legislative session, and that has been a valuable touch point, I think, for us in the department, as well as our colleagues around the agency who are engaged in this and other areas of state government, to be able to hear directly from the advocates and from providers and make sure that we are moving forward in some fashion that keeps this effort in the right direction without exposing us to undue federal scrutiny or risk.
Any questions, committee?
Other than me?
I don't. You've got some, he's got some.
Okay, you?
No, go ahead.
Thank you, Alex, much appreciated. In section 5, which is the burial arrangement thing, does that open this state plan or is that separate?
I don't believe so. I think Addie would be able to talk to that, but I don't think that touches the state plan.
Okay, thank you.
But actually, sorry to jump in. We would have to do a conforming state plan amendment on that provision.
So if I may, so does that open our entire state plan or how because you were worried a little bit about doula, I get it, but how does that, is it similar or are there similar concerns?
I don't want to contradict Alex. We
Please
have to
do.
engage in this back and forth with the federal government. We have been this year, and I think our initial thinking is this one would kind of fly under the radar, but I'm not sure if the exposure that she was referencing would be on the same level as this proposal.
I can tag on to that to say I don't want to speak for Medicaid policy, who are really the folks who have the most expertise in this area. But as I understand it, not every Medicaid state plan amendment is made equal, and some of them expose us to greater amounts of risk or greater concern from the federal government than others.
I guess that we did something, I think, last year with the doulas. They do have to get certified by the state, right? Correct?
That's going to be a question for OPR on their certification
Okay.
process. They have a whole study around that, and we're working with them to make sure their requirements are in line with what we need to see.
We'll save that for them.
What else had they had?
I think, on the prepaid burial, that going from 10,000 to 15 is what the consumer pays, correct? Like this is they purchased the plan and the $10,000 was the limit that we gave them before to make them Medicaid eligible. We're just saying they bought a $15,000 prepaid burial and we're saying that's okay. Right? This is no money out of government pockets at all.
No, I
Correct?
mean, it could mean that very marginally more people are eligible for Medicaid, right? Because there's just like a larger range for these burial funds being set aside. But we think that would be kind of de minimis.
Yeah. I don't see that having an impact at all, and the federal government will look at. Okay. But
And
One more.
okay,
Thank you. I'm sorry, I don't know what preserve monies means. Applicants and recipients to preserve monies. What does preserve monies?
Is that the language related to the burial funds?
Yes, it's in the first, in A.
I think that's just the formulation that says this is an amount of money you can set aside and you don't have to count as a resource as part of your Medicaid eligibility.
Thank you. I appreciate that.
It's being increased from 10 to 15.
So it doesn't get included in your Medicaid analysis.
Okay? Any other questions? Okay, now you had something else that you wanted to bring up too?
Yes,
yes, I'll pass it over. Sorry, go ahead, Addie.
Oh, that's fine. Thanks. I understood that we were asked to provide a brief initial update on open enrollment data, which I'm happy to do. And I'll just jump in. I do have some slides to share, but they're very hot off the presses, so I wasn't able to share them ahead of time. So just for context, we're talking about the Qualified Health Plan open enrollment period, which is part of the Qualified Health Plan marketplace that I think this committee is quite familiar with, but just it's helpful to remember we're talking about a pretty small percentage of our population that gets coverage, healthcare coverage, through this mechanism that is operated by DVHA, also known as Vermont Health Connect. So we anticipated a really challenging open enrollment period this year because of a change in federal policy around the tax credits that were available to Vermonters to offset the costs of their qualified health plans. Specifically, the enhanced federal tax credit that was made available under the American Rescue Plan Act several years ago during the pandemic was set to expire at the end of 2025. So we knew this was going to be a big part of the open enrollment for 2026, is this kind of loss of subsidy and challenges around affordability. So we did a lot of outreach around this, and open enrollment opened on November 1st, and it just ended last week on January 15th. And I think people have been very eager to kind of find out what has happened with enrollment. And I would just like to say that it takes a while for this all to settle out because there was a lot of activity during open enrollment period, which we actually found really encouraging. I think people heard our message around reviewing their options. Our kind of motto for open enrollment was stay informed and stay covered. And we had very high call volume, a lot of different plan selection happening, and I will share a bit of data around that and then also go over where we are in terms of our overall enrollment. Again, this is initial. It's gonna we're going to do some more analysis about kind of what this means and also how it continues to progress as we get into the first quarter of 2026. but we did want to share what we have now. I'm going to attempt to do the screen sharing, which is not my favorite. First, I just wanted to let you know that we're posting a dashboard on our website that has these metrics that I'm going to go over in a way that you can see a bit better than this. But we, knew there was interest both in the customer activity and then in the enrollment data. And so we do have this posted at this time. And we're doing that on a weekly basis.
Can you explain those charts a little bit, please?
Yes, I'm going to actually do a 1 slide per each graph.
Okay, good.
As soon as I figure out how. Okay, here we go. So starting with calls, just wanted to illustrate that our call volume was very high through open enrollment. We actually had one of the highest days in near history in December, recent history in December, toward the end of the plan selection deadline for January 1st coverage. It followed a similar pattern to past years, but obviously just more of everything. The second metric is around the plan comparison tool, which is where people go to shop for plans during open enrollment before they make their final plan selection. This shows a similar story, just a high level of engagement and a high level of use of the plan comparison tool. And so this is the big number, which is that our net enrollment, this is as of January 15th, is at 30,334 people. That is down, and that is as expected because of the affordability challenges that I just described. It's down about 2,400 from our last public report, which we do quarterly, so it was in September, which is about roughly 6% of the qualified health plan population on the exchange. This slide shows the comparison year over year. And as you can see, it's almost an inverse of last year. Last year, we grew really significantly because of the availability of the subsidies, as well as the silver loading concept that Alex referenced in testimony earlier. So it took a while to see that trend of actually becoming lower enrollment than last year, again, because last year was a pretty unusual year. But now we're well below and on that kind of downward trajectory that we do expect to kind of continue into 2026 as people continue to see their bills and make decisions about whether or not to stay enrolled. Within this net enrollment total, there are two kind of trends that I think are worth looking at a little more closely. The first is that we had fewer new qualified health plan customers than we did last year. So that's one of the influencing factors for the total net enrollment being down. The second is around disenrollment, and our disenrollment rate, conversely, was very high compared to past years. And again, you can see those jumps, especially right around December 15th, which was that cutoff deadline for January 1st coverage, and people making choices to no longer remain enrolled in the qualified health plan. And then we had one more graph on this dashboard, which relates to the metal level selection. So metal levels are the different actuarial values of each qualified health plan that you can choose from. They go from bronze up to platinum, with platinum being the kind of richest plan in terms of what it covers and the smallest amount of out-of-pocket expenses for enrollees. And this is taking a little bit to kind of shake out as well, because as you can see, gold is still our biggest enrollment area. That's kind of residual from last year when we transferred a lot of people into gold plans because they were getting better value there than the lower metal levels because of our silver loading policies, which is quite technical. And maybe I can come back to talk more about that if there's interest. But what I wanted to show here is that we are seeing a trend toward people buying into bronze this year because of the affordability challenges, with that bronze percentage increasing 4 or 5% by January 15th. So I can, happy to share those with you all. Again, it's posted publicly on our website. Our next step is to look at this attrition that we're seeing kind of by income level and confirm our strong expectation that that is because of the loss of the enhanced subsidies, expecting to see a lot of those people who are over 400% of the federal poverty limit choosing to either buy down into a lower meta level plan or disenroll altogether. And then I didn't say this explicitly, but those subsidies did expire. So we now have a lower percentage of subsidized enrollees. Before, in 2025, it was in the low 90s. Now it's around 75%. We also saw the average net premium double, which was what we projected would happen with the loss of the subsidies. And then the overall amount of the subsidies coming into our state has decreased significantly with this expiration. It's a really challenging environment, but on a policy level, those conversations are happening in Washington. We hope to support Vermonters as much as we could through it in terms of maintaining coverage, and we'll continue to analyze exactly what that looks like as we get into 2026.
Okay, thank you. Any questions about this?
So I noticed that the silver level reduced by about 8% and the bronze went up by 4%. First of all, does that, do you have like people numbers for those percentages? Maybe you don't yet, but I'm just wondering how many, does that reflect so many people now being completely uninsured or underinsured?
Sure. Yeah, it's a combination of both. I don't have the raw numbers off the top of my head, but I'm happy to get them. We definitely have them.
Okay.
The reduction in silver is really residual from the previous plan year where many people moved out of silver and into gold. So that's less reflective of what's going on this open enrollment than what happened kind of after open enrollment last year. But the increase in bronze is definitely reflective of what's going on this year. So that is that concept of kind of buying down and having higher out-of-pocket costs and potentially being underinsured. In terms of the people who disenrolled, who lost coverage altogether, I think we don't know for sure, but in many cases, it's probably because they don't have another source of coverage and this was unaffordable to them. And that would ultimately impact our uninsured rate, though it's much too soon to tell by how much.
Thank you.
Okay.
We do a household insurance survey like a lot, every 2 years, every 3 years. So when do we do again, and when do you think these numbers would be reflected in that?
That's a question for you all. I think you kind of commission it, if I'm remembering correctly, how that process works. We just did it during 2025, and that showed really significant increases in kind of higher value coverage and people moving into gold plans, and maintaining our overall very low uninsured rate. I think, in the next year or so, you will see the impact of this change. I think we just don't know, because this is such a small portion of the population in the market, how much it will move that overall kind of statewide needle. But yeah, the impact is real, happening now. And so it would be, picked up in any kind of instrument later in 2026.
So you're thinking, if I may,
Go ahead.
so in 2 years did it last year, so do it 1 year from now would be 2 years, but maybe that's too soon. So I'm wondering, is age 611 a technical bill where that could be included? I'm just wondering where we do that, if we wanted to address this.
I can help with this, Leslie.
Great.
We
If I may-
usually put it in the budget. And I was going to ask, actually, if I can jump in, or just point out that the household insurance survey wasn't in the budget last time, that we actually added it, and it didn't come to us in the governor's budget.
I remember that. So
For
would it be
context-
better? Oh, go, sorry.
I'm so sorry. For context, it's usually around every 4 years. That's the tempo that has been done historically. I think before this year, it was 2021. And that is also a kind of joint purview between ourselves and our colleagues at VDH. So I think the actual production of the report lies with VDH, and that language is usually included in the budget bill, as Representative Rebecca said.
So that's the standard location for it. Thank you.
Yeah, just to clarify, DIVA doesn't do the survey.
Yeah.
We reviewed
Okay.
the results. Obviously, it's a very helpful tool, but it's not in our jurisdiction.
Okay, thank you.
Mhm.
Thank you. Mr.
Hopper, I have a
Fisher,
question. I don't know if you can see my hand.
I can't. Can you just hold it for a minute?
Yep.
Daisy?
Healthcare advocate has a question. Thank you. Addie, I think that DIVA estimated the value of the enhanced tax credits in the marketplace study at 65 million. Is the outcome of what actually happened, is that something that DIVA could back into how much premium tax credits Vermont has lost? Is that a reasonable question for you guys to evaluate?
Yes, thanks for asking it that way. We always include that kind of overall annual aggregate amount in our coverage map that we'll aim to produce hopefully next month. But yeah, it's coming out based on enrollment right now. It's coming out to be a bit higher, around 72 million loss.
Thank you very much. Any other questions? Okay, now, Daisy, go ahead.
I have a very important technical question. Where do we find those wonderful charts that you walked us through, Addie?
Sure, I will provide the link to you all, and they're right on the DIVA website under our reports page.
Okay, I've been poking around there. I can't find them, so I'd appreciate the link. And also
Perfect.
just kudos to your staff who pulled those together. They're really, really well done.
Thank you very much.
Any other questions from the
I
committee?
can send Tasha a link for that for the committee.
Okay, good. Any other questions from the committee? Okay, thank you very much. Your testimony is much appreciated.
Thank you both. Always happy to be here.
Good afternoon.
Thank you.